Welcome. In the previous session, we discussed about rhegmatogenous retinal detachment, and in this session, we'll be discussing about the remaining forms of retinal detachment, namely traction, combined, and exudative retinal detachments. Traction retinal detachment occurs when vitreoretinal traction, usually from contractile fibrous or fibrovascular membranes on the posterior hyaloid, detaches the neurosensory retina from the retinal pigment epithelium without formation of a retinal break at the site of a pathological vitreoretinal adhesion. In this diagram, the blue line represents the posterior hyaloid, the red line represents the neurosensory retina, and the brown line represents the RP and the choroid. These green lines represent sites of fibrous or fibrovascular proliferations, which in cases of proliferative retinal neovasculopathies originate from the underlying neurosensory retina itself and then grow over the posterior vitreous cortex, thus forming sites of pathological vitreoretinal adhesions. Then when this posterior vitreous cortex along with these fibrous or fibrovascular proliferations contract, the neurosensory retina is pulled away from underlying RP and choroid at the sites of these pathological vitreoretinal adhesions. This portion of the diagram shows a focal vitreoretinal adhesion which pulls the neurosensory retina in the shape of a tent, and this portion of the diagram shows a broad vitreoretinal adhesion which pulls the neurosensory retina in the shape of a tabletop. This color photograph shows TRD as seen typically in proliferative diabetic retinopathy due to fibrovascular proliferation, typically along the arcades. Causes of TRD include retinal neovascular proliferation, which, as we have mentioned, adhere to posterior vitreous cortex, leading to a firm vitreoretinal adhesion, and when the vitreous body contracts, the area of adhesion is pulled anteriorly, detaching the neurosensory retina from the retinal pigment epithelium. And the entities which lead to TRD in such a manner include diabetic retinopathy, retinopathy of prematurity, retinal venous occlusions, retinal vasculitis, and Coats disease. And as we have mentioned, these are more common along temporal arcades where vitreoretinal adhesion is stronger. Other causes of TRD include proliferative vitreoretinopathy or PVR, inflammatory conditions of the posterior segment, and penetrating trauma to the posterior segment. We'll be discussing about proliferative vitreoretinopathy in more detail in this session. The surface of the retina in TRD is smooth in contrast to the corrugated appearance of the surface of a rhegmatogenous retinal detachment, has a concave contour in contrast to the convex contour of rhegmatogenous retinal detachment, and is immobile, that is, it does not move with ocular movements, unlike a rhegmatogenous retinal detachment which undulates with ocular movements. A TRD usually remains localized or progresses very slowly over time and does not usually extend to ora serrata, and the contracting membrane causing the TRD can often be recognized on fundus examination as seen here in this clinical photograph. Proliferative vitreoretinopathy or PVR is a non-angiogenic fibrotic entity, that is, it is fibrous and not fibrovascular, occurring as a result of formation of contractile fibrocellular membranes over various surfaces in the posterior segment, most commonly over the inner surface of the neurosensory retina. It is considered as a vitreoretinal wound healing response which leads to tractional retinal detachment, and a retinal break is a prerequisite for PVR to occur, and this is important to remember. The two common scenarios in which proliferative vitreoretinopathy develops are following surgical reattachment of rhegmatogenous retinal detachment and with long-standing untreated rhegmatogenous retinal detachment, and PVR is the most common cause of ultimate failure after surgical reattachment of an RRD, and this is very important to remember. PVR is said to occur in 5 to 10% of RRD eyes following initial surgical reattachment of the RRD. Other scenarios in which PVR can occur are eyes with large retinal breaks in the absence of RRD, following development of retinal breaks in an eye with TRD from another cause, and in an eye with a large choroidal detachment. Risk factors for PVR include number and size of retinal breaks, and eyes with giant retinal tears are particularly prone to develop PVR following surgical reattachment, penetrating trauma, intraocular inflammation, vitreous and subretinal hemorrhage, choroidal hemorrhage and effusions, number of posterior segment surgical procedures, and intraoperative risk factors such as excessive cryotherapy, failure to close retinal breaks, and certain conditions which require extensive posterior segment surgical procedures. Three elements play major role in pathogenesis of PVR: RPE cells, retinal glial cells, and growth factors. Following a retinal break, RPE cells get dislodged and migrate through the retinal break into the vitreous cavity and settle on various surfaces in the posterior segment. After getting dislodged from the retinal pigment epithelial layer, these RPE cells transform into myofibroblasts, which adhere to extracellular matrix and also secrete various components of extracellular matrix such as collagen. This results in formation of contractile surface membranes on various surfaces in the posterior segment, such as the inner and outer surfaces of the neurosensei retina, the posterior vitreous cortex, and the ciliary body. And because of the effect of gravity, these membranes develop most commonly in the inferior quadrants of the eye. The second element in the pathogenesis of PVR are the glial cells of the retina, mostly the Muller cells, which are activated as a response to detachment of the retina, and proliferate, which is called reactive gliosis. The glial cell processes migrate into the epiretinal and subretinal spaces and integrate with the surface membranes there, and in addition, reactive gliosis within the retina cause retinal shortening and neuronal degeneration. The third element in the pathogenesis of PVR are growth factors and cytokines, whose levels are increased in the vitreous following RRD. These growth factors and cytokines originate from RPE and glial cells, breakdown of blood-retina barrier at the retinal break, and from inflammatory cells. Released growth factors and cytokines mediate RPE and glial cell proliferation, cellular migration, transformation of RPE cells into myofibroblasts, and ECM contraction. Contraction of these surface membranes result in wrinkling and full thickness fixed folds of the retina, opening up of previously closed retinal breaks, and occurrence of new retinal breaks, ocular hypotony from ciliary body detachment, and shortening of the retina, which makes it difficult to close retinal breaks and reattach the retina. After surgical reattachment of RRD, PVR usually develops in 4 to 8 weeks, and retinal morbidity from PVR varies from epiretinal membrane formation in mild PVR to funnel-shaped total retinal detachment in severe PVR. Early signs of PVR include marked vitreous haze and pigment clumps in the vitreous, along with increased stiffness of the detached retina, with limited mobility of the detached retina during ocular movements. Then wrinkling of the inner surface of the retina develops, as seen here in this color photograph, followed by development of full thickness fixed retinal folds, as seen here in this color photograph. Contraction of a focal and localized surface membrane leads to the development of star folds, which occur due to a localized focus of contracted preretinal membrane, which induces full thickness radial retinal folds in the surrounding retina, and these radial folds pull on the anterior retina and create new retinal breaks. Larger membranes form diffuse retinal folds, which often lead to the formation of funnel-shaped RDs, as seen here in this clinical photograph. And subretinal fibrosis gives a Swiss cheese appearance to the subretinal space, as seen here in this color photograph. Retinal vessels appear tortuous because of the wrinkles and folds on the retina, and retinal breaks may have rolled over edges or may appear stretched open. Still later, the detached retina can take up a funnel-shaped configuration, obscuring the visibility of the optic disc, and circumferential contraction of surface membranes on posterior or peripapillary retina result in a posterior funnel configuration of the detached retina. Circumferential contraction of surface membranes on anterior or equatorial retina result in an anterior funnel configuration of the detached retina, and anterior loop traction on anterior retina occurs due to contraction of membranes extending from the vitreous base to the anterior retina, resulting in the formation of a peripheral retinal trough near the ora serrata. Contraction of surface membranes on ciliary body can result in ocular hypotony due to ciliary body detachment and anterior chamber cells. Dilated iris vessels and iris neovascularization may be found in an eye with PVR. USG-B scan in eyes with PVR shows immobile fixed retinal folds in the detached retina along with prominent vitreous membranes. Surface membranes of PVR are difficult to identify on an attached retina, and when an old retinal break reopens or a new retinal break develops due to contraction of these surface membranes, there is dramatic contraction of the redetached retina, giving an impression of sudden development of severe PVR. The original classification of PVR grade, developed in 1983, describes eyes with vitreous haze and vitreous pigment clumps as having grade A PVR, eyes with wrinkling of inner retinal surface, rolled edge of retinal break, retinal stiffness, and vessel tortuosity as having grade B PVR, eyes with full thickness retinal folds as having grade C PVR, with C1 representing full thickness retinal folds in one quadrant, C2 representing full thickness retinal folds in two quadrants, and C3 representing full thickness retinal folds in three quadrants. And when full thickness retinal folds are present in all four quadrants, the eye is labeled as having grade D PVR, with D1 denoting a wide funnel, D2 denoting a narrow funnel, and D3 denoting a closed funnel. But this classification does not describe the location of PVR, either anterior or posterior, and the type of PVR. The updated classification of PVR, developed in 1991, has a grade classification and a contraction type classification. Grades A and B of the updated PVR grade classification were similar to grades A and B of the original PVR grade classification, and grade C of updated PVR grade classification was further subdivided into grade C PVR posterior to equator and grade C PVR anterior to equator, with 1 to 12 representing the number of clock hours of involvement with grade C PVR. Grade C PVR posterior to equator included full thickness retinal folds, either focal, diffuse, or circumferential, and subretinal strands posterior to the equator, and grade C PVR anterior to equator included full thickness retinal folds, either focal, diffuse, or circumferential, subretinal strands, and anterior displacement of the retina, all located anterior to the equator. Contraction type classification includes focal posterior PVR, which indicates star fold posterior to the vitreous base, diffuse posterior PVR, which indicates confluent star folds posterior to the vitreous base, subretinal PVR, either anterior or posterior, circumferential anterior PVR, which indicates contraction along posterior edge of the vitreous base, and anterior PVR, which indicates vitreous base being pulled anteriorly with the formation of a peripheral retinal trough. But none of the grading systems, either the original or the updated, describe cellular activity, consider intraretinal fibrosis or retinal shortening, and correlate with anatomical or visual prognosis. Differential diagnosis of PVR include other causes of TRD, other causes of ocular hypotony following RRD repair, and a localized retinal detachment posterior to a scleral buckle due to contraction of surface membranes, but these are stable and do not progress. PVR in an eye with an attached retina and without retinal breaks do not require treatment unless macula is involved. Macular pucker due to ERM formation from PVR causing metamorphosia and diminished visual acuity requires removal of the ERM by membrane peeling, and management of an eye with RRD and PVR depends on the location and severity of the PVR and location of open retinal breaks. In rare cases of PVR with RRD, scleral buckling alone may suffice, particularly when PVR is localized, distant from the retinal break, and thus not interfering with closure of that retinal break by the scleral buckle. But in most cases of PVR with RRD, vitrectomy with peeling, that is removal of surface membranes, is required because in most cases surface membranes are located near the open retinal breaks and interfere with closure of the breaks by scleral buckling alone. The aim of vitrectomy in PVR with RRD is to relieve all existing traction on the retina and close any open retinal breaks. and the peeling of surface membranes can be facilitated by using perfluorocarbon liquid, which makes the surface membranes more easily detectable and acts as a third hand during removal of these membranes. Vitreous-based dissection is required if membrane peeling from the posterior pole does not settle the retina, and a relaxing retinotomy or retinectomy may be required if retinal shortening prevents reattachment of the retina, and if subretinal bands interfere with closure of retinal breaks, they need to be sectioned or removed through a retinotomy. Following membrane peeling, internal drainage of subretinal fluid with fluid air exchange and photocoagulation of all retinal breaks is performed, and we have discussed these procedures in the previous session. At the end of the procedure, internal tamponade with either perfluoropropane gas or silicone oil is employed, and the silicone study found that in eyes with severe PVR, C3F8 and silicone oil have similar anatomical and visual outcomes, and both were superior to sulfur hexafluoride gas for internal tamponade. Other studies suggest that silicone oil gives a better visual outcome in eyes with anterior PVR, and heavy silicone oil, which is denser than water, is often preferred in eyes with inferior PVR. And a circumferential scleral buckle is often used along with vitrectomy in these eyes to support the contracted vitreous base. Timing of surgery for PVR is a matter of debate, as a detached macula needs to be attached as early as possible, but on the other hand, membrane peeling and retinotomies or retinectomies in early PVR when cellular activity level is high can accelerate the PVR process. So an alternative option suggested is stepwise surgery, in which vitrectomy and intraocular tamponade to settle the macula is performed in the first sitting, followed by retinectomy or retinotomy after 3 to 6 months if any part of the retina remains detached after the first surgery. 50% of fellow eyes of eyes with PVR have vision-threatening lesions such as retinal breaks and lattice, and many recommend prophylactic therapy of these fellow eyes. Anatomical success rate, that is retinal attachment for at least 6 months following surgery after a single surgical procedure for PVR grade C, has been reported to be 80%, but visual outcomes are often disappointing. Despite successful surgical treatment for PVR, PVR can recur, and pharmacologic agents have been tried to reduce the recurrence of inflammation and fibrosis, but without much success. Combined traction and rhegmatogenous retinal detachment occurs when vitreoretinal traction causing a TRD creates a retinal break in the detached retina. The retinal break usually occurs at the site of vitreoretinal traction causing the TRD, and following creation of the retinal break, vitreous fluid passes into the subretinal space as in a rhegmatogenous retinal detachment. The detached retina thus changes from a concave to a less concave or convex configuration, and the surface of the detached retina changes from a smooth to a corrugated appearance. The subretinal fluid does not remain localized to the zone of the original TRD, but extends beyond that zone and may extend from the optic nerve head to the ora serrata. Exudative or serous retinal detachment is accumulation of fluid in the subretinal space in the absence of retinal break or vitreoretinal traction, and can occur due to either excessive fluid leakage into the subretinal space due to dysfunction of inner blood retina barrier at the retinal blood vessels, dysfunction of outer blood retina barrier at the RPE, or due to congenital structural defects such as optic disc pits, or deficient outflow of fluid from the subretinal space due to deficient absorption by dysfunctional RPE, or poor outflow through the sclera. Inflammation and neoplasia are the leading causes of exudative retinal detachment, and this is very important to remember. And it is important to distinguish exudative retinal detachment from rhegmatogenous and traction retinal detachment, as treatment of exudative retinal detachment is primarily non-surgical. Exudative retinal detachment from disruption of blood retina barrier can occur from inflammation, which can be either non-infectious such as Vogt-Koyanagi-Haradas disease, sympathetic ophthalmia and sarcoidosis, or infectious such as tuberculosis and syphilis, from tumors such as choroidal melanoma, choroidal hemangioma, choroidal metastasis, and retinoblastoma, from bilateral diffuse uveal melanocytic proliferation, which is a paraneoplastic entity, from retinal and choroidal vascular diseases such as Coats disease, severe diabetic retinopathy, retinal venous occlusion, and choroidal neovascular membranes, from choroidal occlusion with destruction of overlying RPE, as in malignant hypertension and disseminated intravascular coagulation, from central serous chorioretinopathy, particularly its acute bullous and chronic form, from structural defects such as optic disc pit, optic disc coloboma, and morning glory anomaly, from panretinal photocoagulation and cryotherapy, from chronic renal failure and hypoalbuminemia, from post-operative hypotony, and from medications such as MEK inhibitors, interferon alpha, topiramate, and immune checkpoint inhibitors. Exudative retinal detachments from poor scleral outflow, in which choroidal detachments are also found, can occur from uveal effusion syndrome, posterior scleritis, following scleral buckle, dome-shaped macula of myopia, and in patients with carotid cavernous fistula. An exudative retinal detachment typically has a smooth and convex surface. So the surface of an exudative retinal detachment is convex like that of the surface of a rhegmatogenous retinal detachment, but unlike the surface of a rhegmatogenous retinal detachment, the surface of an exudative retinal detachment is smooth and not corrugated. A classic feature of exudative retinal detachment is shifting of subretinal fluid with change in head position, and this is very important to remember. The subretinal fluid in exudative retinal detachment moves under the action of gravity within seconds to minutes. So when the patient is in an erect posture, subretinal fluid typically accumulates in the inferior quadrants of the retina, and then when the patient is made to lie down in a supine position, subretinal fluid shifts and accumulates in the posterior pole of the retina. And the features of the entity causing exudative retinal detachment can often be found on fundus examination. Evaluation of a patient with exudative retinal detachment includes blood pressure measurement to rule out malignant hypertension, B-scan ultrasonography, which shows the exudative retinal detachment as a smooth dome-shaped elevation of the retina, and shifting of the exudative retinal detachment can be elicited on B-scan ultrasonography. B-scan ultrasonography can also elucidate the cause of exudative retinal detachment, such as a choroidal tumor, posterior or panuveitis, and posterior scleritis. Other diagnostic modalities include OCT, fundus fluorescent angiography, and indocyanine green angiography, thoracosystemic evaluation by an internist, hematologic evaluation and serology, imaging of orbit, brain, and any other region of the body as required, and lumbar puncture. Treatment and prognosis of a patient with exudative retinal detachment depends on the cause of exudative retinal detachment, and usually visual prognosis following treatment is better in exudative retinal detachment as compared to that in rhegmatogenous or traction retinal detachments. Differential diagnosis of retinal detachment includes differentiating between the three types of retinal detachment: retinoschisis, which we will be discussing in the next session, choroidal detachment, and choroidal tumors. Choroidal detachment appears as an orange to dark brown, smooth-surfaced solid appearing immobile convex elevation, usually delimited by ampulla of vortex veins. To recap the salient points, traction retinal detachment occurs when vitreoretinal traction, usually from contractile fibrous or fibrovascular membrane on posterior hyaloid, detaches the neurosensory retina from the retinal pigment epithelium at sites of pathological vitreoretinal adhesions. Causes of traction retinal detachment include retinal neovascular diseases, inflammatory entities, proliferative vitreoretinopathy, and posterior segment penetrating trauma. The detached retina in TRD has a concave configuration, a smooth surface, is immobile, and rarely extends up to the ora serrata. Proliferative vitreoretinopathy typically occurs following surgical reattachment of a rhegmatogenous retinal detachment or in eyes with long-standing unoperated rhegmatogenous retinal detachment. RPE cells migrate through the retinal break into the vitreous cavity, settle over the retina, transform into myofibroblasts and form a contractile fibrous membrane on the anterior and posterior surfaces of the retina. Processes of activated glial cells and growth factors contribute to this process. The contractile membrane can wrinkle the retina, open previously closed retinal breaks, form new retinal breaks, and detach the ciliary body. PVR typically develops 2 to 3 months after the initial rhegmatogenous retinal detachment. Early clinical features include vitreous haze, clumps of pigment cells in anterior vitreous, and wrinkling and stiffness of the detached retina. Later, full thickness fixed folds of the retina can be detected. Eventually, circumferential contraction of surface membranes can lead to posterior funnel and or anterior funnel configuration of detached retina, and anterior loop traction of anterior retina can also occur. Ciliary body detachment can lead to ocular hypotony. Management of PVR is primarily surgical. Vitrectomy is required to relieve all traction causing membranes, allowing reattachment of retina and closure of all retinal breaks, followed by internal tamponade with C3F8 gas or silicone oil. Combined traction rhegmatogenous retinal detachment occurs when a retinal break develops in an eye with a traction retinal detachment. Usually the retinal breaks occurs at the site of vitreoretinal traction, causing the traction retinal detachment. Following development of retinal break and seepage of vitreous fluid into subretinal space, the retina becomes less concave or convex and develops corrugations. The subretinal fluid does not remain restricted to the area of tractionally detached retina and may extend up to optic nerve head and ora serrata. Exudative retinal detachment is the accumulation of fluid in the subretinal space in the absence of retinal break or vitreoretinal traction. It occurs either due to disruption of inner and or outer blood-retina barriers or poor outflow of fluid through the sclera. The detached retina appears smooth and convex and typically shifts with change in head position. The two most common causes of exudative retinal detachment are inflammatory entities and neoplasias, and other causes include retinal vascular diseases, diseases causing choroidal occlusion, central serous chorioretinopathy, panretinal photocoagulation, structural defects, drugs, and outflow obstruction. Thank you for listening.